Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. And to all of you listening, especially those of you already back in the clinic, on the wards, or in the OR, a very happy new year.
Happy New Year.
We know the pace never really slows down, which is why we're jumping straight into two critical, high-stakes nutritional syndromes. They might feel like textbook concepts, but when they actually present, they demand immediate and very specific recognition.
That's right. Today, we're doing a comparative deep dive into refeeding syndrome, or RS, and dumping syndrome, DS. And while both conditions involve these profound physiological responses to nutrition, they are mechanistically, worlds apart.
Absolutely, in their triggers, their presentation, and definitely in how you manage them.
Exactly.
So our mission today is to pull out the critical contrasting pieces of information on pathophysiology, diagnosis, and management for both. We want to give you a clear conceptual blueprint to intervene quickly and, prevent serious morbidity.
Think of it as a clinical shortcut, a way to avoid two very different but equally dangerous nutritional traps. And because these are high acuity scenarios, we have to state this right up front.
The disclaimer.
Yes. This content is for intellectual insight and reference only. In your clinical practice, you absolutely must adhere to your local hospital guidelines and protocols. This is to sharpen your understanding, not to replace those directives.
Okay, let's unpack this. We'll start with the metabolic firestorm. Refeeding syndrome. The name alone sounds terrifying. What's the simple core concept we need to lock down first?
The core concept is that RS is a life-threatening and very rapid shift in fluids and electrolytes. It's almost universally triggered by reintroducing nutrition.
Any kind of nutrition.
Any kind. It doesn't matter if it's oral, enteral tube feeds, or IV parenteral nutrition. The trigger is feeling a patient who is profoundly malnourished. The classic signs are a quartet of dangerous biochemical abnormalities: severe hypophosphatemia, hypokalemia, hypomagnesemia, and a very precarious fluid balance.
Okay, what's crucial here is understanding why this happens. During starvation, the body's in conservation mode. What happens physiologically the moment you start pushing calories back in, especially carbohydrates?
It's a syndrome of, metabolic reboot. During that starvation state, that catabolic ketogenic state insulin is suppressed. The body is running on fat and protein. But, and this is critical, the patient's intracellular stores of minerals are becoming dangerously depleted.
Even if the blood tests look okay initially.
Precisely. Then you introduce carbohydrates, and that triggers an overwhelming surge of hyperinsulinemia.
And that insulin surge acts like a key unlocking the cell doors, but it's pulling in more than just glucose.
Exactly. Insulin drives glucose rapidly into the cells, but in that process, it just drags phosphate, potassium, and magnesium along with it. These minerals are crucial cofactors for all the anabolic reactions that suddenly switch on protein synthesis, ATP production.
So because those intracellular stores were already bankrupt, the sudden demand just crashes the serum levels.
It causes a precipitous, life-threatening drop. That's the hypophosphatemia and the other electrolyte issues that define the syndrome. The mineral deficiency you measure in the blood is actually a reflection of the minerals rushing away from the blood and into the cells.
That makes the mechanism so much clearer. But you mentioned fluid as well.
Yes, we can't forget the fluid component. Insulin also stimulates the kidneys to reabsorb sodium and water, which puts the patient at a high, immediate risk for fluid overload and, acute heart failure.
It sounds like a cascading disaster. And there's one specific vitamin you mentioned that's often overlooked until it's too late: thiamine.
Absolutely vital. Thiamine, vitamin B1, is a critical cofactor for carbohydrate metabolism. If you refeed a patient who has marginal thiamine stores, those stores are consumed almost instantly. Without it, you risk severe permanent neurological damage. We're talking Wernicke's encephalopathy or acute high-output cardiac failure.
So thiamine supplementation is just non-negotiable.
Non-negotiable.
This really drives home that refeeding syndrome is a disease of pre-existing nutritional depletion. So who are the high-risk patients we need to be identifying before we even think about starting a feed?
You need a high index of suspicion in any patient with severe chronic malnutrition. The classic examples are patients with anorexia nervosa, chronic alcoholism, or certain oncology patients. But also, don't forget social isolated elderly patients.
And are there specific risk factors to look for?
Yes. Specifically, look for acute weight loss, say greater than 10% of their body weight in the last month or two, or prolonged minimal intake. If someone's had negligible calories for over 7 to 10 days, they are high risk.
And what about pre-feeding lab work? Any red flags there?
A huge one. If a patient comes in with low serum potassium, phosphate, or magnesium before you even start feeding, they're already on the knife's edge. They require maximal vigilance.
So how quickly does this unfold, and what are the severe signs we can't afford to miss? What's the most dangerous mistake a clinician can make here?
The most dangerous mistake is misattributing the signs. The onset is rapid, usually within 2 to 5 days of starting nutritional support. And the initial signs are so vague, fatigue, some peripheral edema, maybe mild confusion.
But it gets much worse. Let's focus on those critical, life-threatening presentations.
The hypophosphatemia leads to ATP depletion, which hits high-energy organs hard. You can see acute respiratory failure from diaphragmatic weakness. Cardiac complications are lethal severe arrhythmias, specifically QT prolongation, which can lead to torsades de pointe, and sudden cardiac death.
And neurologically.
Seizures, profound muscle weakness leading to rhabdomyolysis, and as we said, Wernicke's. The diagnostic hallmark, though, is biochemical. It's a serum phosphate less than 0.65 millimole or a significant drop more than 0.16 millimole after you start feeding. Monitoring phosphate is your earliest warning.
Okay, so if RS is this catastrophe waiting to happen, management must be almost entirely focused on prevention. Let's run through the nice guidelines-based strategies.
Prevention is the only effective management, truly. Step 1 is immediate risk stratification. If they're high risk, the mantra is start low, go slow.
What does that mean in practice?
You initiate nutrition at a significantly reduced rate, maybe 10 gellicolch a day, sometimes even as low as 5, and then you increase that rate very slowly over 4 to 7 days. That slow pace allows the body to catch up.
And you can't wait for the labs to drop before you act.
No. You must correct pre-existing electrolyte deficits before the feeds begin. And specific supplementation is mandatory. High-dose 4-thiamine, 200 to 300 milligrams daily, given before and during the initial refeeding.
What about monitoring in those first few critical days?
It has to be intensive. Daily electrolytes for the first 3 to 5 days, and if they're very high risk, check them twice daily. You need frequent ECG monitoring for QTC changes and meticulous fluid balance tracking.
And for the absolute emergency severe symptomatic hypophosphatemia, let's say below 0.32 millimole.
That requires 5-E phosphate replacement. And for the fluid issue, you restrict fluids initially, usually around 20 to 25 milliliter a day, to mitigate that insulin-driven water retention. It's a delicate balancing act.
That's a fantastic framework. Now let's pivot completely. While RS is a catastrophe of restart in a starved body, our next topic, dumping syndrome, is a catastrophe of reroute in a surgically altered one.
A completely different clinical paradigm, you're right. Though its trigger is also food, this is almost exclusively the domain of the post-surgical patient.
Let's nail the definition. DS is a constellation of debilitating vasomotor and GI symptoms. It's caused by the rapid emptying the dumping of hyperosmolar food directly into the small intestine. And we classify it as early or late, right?
Correct. Early is within about an hour of eating, and late is 1 to 3 hours after a meal. The fundamental cause is the surgical loss of the pyloric sphincter, which is the body's natural brake.
Which surgeries are the main culprits?
The most common are Roux-en-Y gastric bypass and, to a lesser extent, sleeve gastrectomy. The stomach essentially loses its reservoir function and its control valve.
Okay, let's detail the two distinct pathophysiologies, because the treatment really depends on which one is dominant. Let's start with early dumping. What's causing that profound discomfort right after eating?
Early dumping is an osmotic crisis. A big lump of hyperosmolar food, especially simple sugars, hits the jejunum and creates this huge osmotic gradient. It pulls fluid aggressively from the patient's blood into the bowel.
And that causes two problems at once.
Two problems. Severe bowel distension, which causes cramps and diarrhea, and acute transient hypovolemia low circulating blood volume. That's what triggers the dramatic vasomotor responses. The patient feels like they've gone into shock and needs to lie down because their blood volume has literally shifted into their gut.
And that's where the flushing and palpitations come from.
Exactly. That stress leads to a release of vasoactive peptides like serotonin and neurotensin.
Okay, now for late dumping. This is fundamentally different. It's not osmotic, it's hormonal.
It is. Late dumping is primarily reactive hypoglycemia. The rapid absorption of carbohydrates causes this exaggerated massive spike in blood glucose. The pancreas overreacts, releasing a huge surge of insulin. But the insulin peak lags behind, hitting 1 to 3 hours later, causing true symptomatic low blood sugar.
So the timing of symptoms is a huge clue. What are the classic presentations of each?
Early dumping, the most common form, hits during or right after a meal. You get GI symptoms, explosive diarrhea, severe cramping, and vasomotor ones flushing, palpitations, tachycardia, and this overwhelming desire to lie down.
They look and feel genuinely unwell. And late dumping.
Late dumping is 1 to 3 hours later, and since it's purely from low blood sugar, the symptoms are all neuroglycopenic. Sweating, tremor, profound weakness, confusion, sometimes even syncope. It's a classic hypoglycemia picture.
Diagnosis is mostly clinical then, based on history.
History's everything. You can use scoring systems like SIGSTAD score, but if you need objective confirmation, the modified oral glucose tolerance test is the gold standard, though it's rarely needed. For early dumping, you're looking for signs of that hypovolemia, a heart rate rise, or a hematocrit jump. For late dumping, it's documented hypoglycemia.
Since surgery caused this mechanical change, the management is very clearly tiered. You start with intensive dietary modification. What are the first-line instructions?
This is the most critical step where most patients find relief. Small, frequent meals, 6 to 8 a day. But the single most important rule is the separation of fluids from solids by at least 30 minutes.
That separation minimizes the hyperosmolar washout, correct?
Precisely. It reduces the osmotic load. Secondly, they have to drastically limit high glycemic index carbs. No sugary drinks, no white bread. Instead, they need to increase protein, healthy fats, and soluble fiber, which physically slows everything down.
And if that strict diet fails, then we move to pharmacotherapy. What about for the late hypoglycemic form?
For late dumping, acarbose is often the drug of choice. It's an alpha-glucosidase inhibitor. It just slows down carbohydrate digestion in the intestine, which blunts that rapid glucose spike and the big insulin response.
And for the really refractory severe cases, that's where you bring out the big guns, like somatostatin analogs.
Right. For severe, debilitating symptoms where nothing else has worked, we use long-acting octreotide. It works by broadly inhibiting a lot of GI peptides and insulin, effectively putting the brakes on the whole system.
And what about revision surgery? How often is that actually an option?
Thankfully, very rarely. Surgical intervention is the absolute last resort. We're talking less than 2% of patients. The procedures are complex, high risk, and are reserved for specialist centers.
This is great. Let's synthesize this. If you're called to the bedside for an acute nutritional crisis, how do you quickly contrast RS and DS in your head?
Okay, 5 key points. First, the core problem. In refeeding syndrome, it's a metabolic shift in a starved patient. In dumping syndrome, it's rapid gastric emptying after surgery.
The primary cause. RS is from refeeding after malnutrition. DS is from the surgical alteration of the GI tract.
Key lab marker. In RS, the cardinal sign is severe hypophosphatemia. In DS, it's reactive hypoglycemia in the late form.
And timing is a huge differentiator. RS happens days after you initiate nutritional support. DS happens minutes to hours after each meal.
And finally, the role of surgery is completely inverted. RS is a medical emergency. Surgery has no role. DS is a post-surgical complication where surgery is an option of last resort.
That synthesis is perfect. It really clarifies how divergent these pathways are. It all comes down to understanding the physiology of the starved versus the rerouted patient.
It really does. Both syndromes underscore just how critical it is to understand nutritional physiology. RS is a ticking metabolic time bomb. DS is a mechanical and hormonal malfunction.
An excellent way to put it. Knowing if you're treating a metabolic firestorm or a post-surgical plumbing issue is half the battle. We wish you all a productive and successful clinical year ahead.
Absolutely. Thank you for joining us for this deep dive.
If you found this information valuable, please don't forget to share this with at least one of your colleagues or friends and help spread the word. And do check out our YouTube channel and other social media pages for more detailed content.
And one last time, our mandatory reminder, this content serves as a reference guide only. Always, always adhere to your specific local guidelines and protocols in your clinical practice.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.